Hello and good afternoon, everyone. Welcome to our presentation of DoMore Diagnostics and how we decode tumor histology to personalize cancer treatment. I'm Torbjørn, the CEO and co-founder of DoMore Diagnostics, and with me also I have our medical director, Saal. And AI and digital pathology is set to transform cancer precision oncology. And what you see on the screen is a tumor, and this holds the key information of the malignancy potential of the tumor and the potential benefit of treatment. And there are several factors that comes into play, and the genomic profile is of course important. If you have mutations, you need mutations to develop cancer. But there are also a lot of other factors that are important. It's the transcription of the gene, the interplay between the genes, so the epigenetics, resulting in the tissue patterns, the morphology of the tumor. Then you have the stromal compartment, so the connective tissue around the tumor is also now understood to be very important to understand the metastatic pattern of the tumor. Heterogeneity, internal variation within the tumor, also a very important factor. And now also with the breakthrough of immunotherapy, we know that the microenvironment is also important. So there's a lot of factors. There are a lot of factors that are important, but until today, the main focus have only been on the genomic profile. Now with the AI and deep learning, we can do a deep assessment of the tumor and understand what these patterns actually mean. Our technology can be used in all cancers. We have focused on colorectal cancer, and this is a very large indication. 1 million patients every year get stage 2 or stage 3 cancer, so locally advanced cancer, where surgery is the main treatment for the patient. And most patients are cured by the surgery, but still after the surgery, there is an important decision to make. Do we add chemotherapy to reduce the risk of recurrence, or does a patient go to observation, remain healthy and no toxic treatment? And of course it is attractive to reduce the risk of recurrence, but it comes with a significant price for patients, with serious or life-threatening side effects for half of the patients, even patients dying from the treatment itself. And also after treatment, many patients struggle with chronic health issues and never fully recover with fatigue, depression, neuropathies, and so on. So it's really critical for patients to understand and know that treatment is justified. And also for healthcare systems, there is now a big savings potential because there is a significant over-treatment today of patients. So a 3 billion euro saving is possible by implementing our colorectal cancer test on a global basis. So our test is trained on 5,000 patient cases, where we have linked it to patient outcomes, survival and recurrence. So we take from the resection, we take a whole slide image, do a segmentation of the tumor area, and then make tiles, and we do it in 10x and 40x, and we see that is actually quite valuable because there are different information that can be understood from the algorithm in the different resolutions. And then we have 5 ensembles that are selected, the best 5 ensembles of all the models we have trained for 10x and for 40x. And together they make up the prognostic decision for the patient, whether it's a good prognosis, poor prognosis, or an in-between prognosis. So what we have is a digital biomarker that can guide personalized treatment. There's a test report you see on the screen that can be used in the multidisciplinary teams deciding the follow-up of the patients after surgery. We have publications in the Lancet that also explains a bit more about the algorithm. We have patents around the technology. We are CE marked, and we have also ISO 13485 certification. And we are GDPR compliant, so all those formalities are in place. This is a more an overview of the test report as such. You see the image that is analyzed, the tumor segmentation and the heat map from 10x and 40x, resulting in the outcome from the algorithm alone. And then we also add tumor and lymph node information to provide an overall risk of the patient. And that is what will then determine the overall risk of recurrence and death from the cancer. It's a very simple implementation, so we use the routine H&E slide that are made for all patients. It's trained on one slide and then also validated on one slide, which is selected by the pathologist as the most representative of the cancer. So we use that slide. We need a digitization, and then we can analyze the slide either by implementing on the image management system if the lab is digital, or if they're not, they can upload to our web portal in the cloud. Having a solid technology and simple logistics is not enough to bring such an invention to patients. We also need solid clinical data. So now I will give it to Leo that will take you through all the clinical validations we have so far.
Right, so I hope you all now have a general good understanding of how our technology works. Over the next few slides, I will review some of our clinical data that we've published and made public. So this Kaplan-Meier curve comes from our first independent validation study that was published some years ago in the Lancet Oncology. And what you can see is that Histotype PX is excellent at discriminating between patients with low, intermediate, and high risk of poor survival. This is all performed in the Quasar-2 clinical trial material. What you can also see is that a very large fraction of the patients actually belong to this low-risk group. In this analysis, in this study, 41% of patients belong to this low-risk group, which has a very excellent 5-year survival of 96%. And as Torbjørn mentioned before, if one generates additional evidence that can show that these patients really may not benefit from chemotherapy, one can save toxic treatment from patients who may not actually be benefiting from this treatment. So that's the question. How are patients who do not receive chemotherapy, how are they actually faring? So we performed a study together with the Ohio State Comprehensive Cancer Center. This is an interim analysis that we presented last year at Pathology Visions. It's 87 patients who all did not receive chemotherapy. And what you can see is the patients in the top curve had very excellent outcomes. 93% had a 3-year recurrence-free survival, and 95% of patients had a 5-year cancer-specific survival. And again, in this study, the number of patients belonging to the low-risk group was very large, almost 3/4. More recently, we've done an additional validation study together with the University Medical Center in Utrecht of 450 patients who also did not receive chemotherapy. These are, again, stage 2 and stage 3 patients. And what you can see, again, is that Histotype does an excellent job of discriminating patients with low, intermediate, and high risk. And the low-risk group has a 3-year cancer-specific survival of almost 94%. So we think that these kind of results can give additional information to oncologists to perhaps consider safely avoiding chemotherapy in patients who are minimally benefiting from chemotherapy. But we do need more data, and we have some more that goes in this direction. We did a validation study together with the Japanese group who ran the Circulate Japan study. If you're not aware, Circulate Japan is a seminal study that's resulted in many publications showing the value of ctDNA analysis in colorectal cancer. So we were able to analyze just over 1,000 patients from this cohort, the so-called Galaxy cohort. And what I'm showing here on the left side are all the patients who were ctDNA negative at the MRD landmark time point. So that's the first time point after surgery. And now we've taken those patients, which were actually the majority of patients are landmark negative, and what we're showing here is that Histotype can still add additional value and further stratify these MRD negative patients into low and high risk groups with significant differences in outcome. And what's really interesting is this curve here, which again are the MRD negative patients, which are all low risk. And the two curves indicate the patients that were treated with chemotherapy or by observation alone. And so here you can see that the two curves are essentially overlapping. The hazard ratio is basically 1 and non-significant. Again, giving us more evidence that perhaps these patients who are lowest risk using our test may not be getting much benefit from chemotherapy. So in addition to these results, another great feature of the Histotype method is that, of course, it uses the H&E slides, which means once the surgical resection is performed and the H&E slides are prepared, within just a day or two from that time point, a Histotype result can be delivered back to the clinicians who are making decisions. So if a patient is Histotype high risk, an oncologist should probably start chemotherapy right away and not even bother to wait for the MRD result. This patient is high risk, and conversely, if they are low risk, it may be a signal that perhaps chemotherapy may not be necessary. In addition to this, I can point out that MRD does have a false negative issue, and about 2/3 of the false negatives from ctDNA are identified as high risk, can be identified by high risk by our test. So just to dive into the Galaxy data in a little bit more detail, out of 1,082 patients, there were 191 patients that had a recurrence. So ctDNA was positive in 60% of these patients. With our test, 69% of patients were intermediate or high risk, but as you can see here, they're identifying slightly different groups of patients, and it's really the combination of the two which identifies almost all of the recurrences, 86% of the recurrences. And so we see a great complementarity between using ctDNA together with histotype analysis. I wanted to point out that we also have a poster being presented just over here in this corner, poster number 52, so I encourage you to come and check it out. It's ongoing right now. And I'll just present some of the data that we're showing from the poster in case you don't have time to see it later. This is, again, a collaboration with Ohio State University, sort of an expansion upon the previous study where we've looked at now 503 cases. And these are real-world data, so these are patients seen in the real world. And again, Histotype shows excellent performance. The low-risk group has a 94% 5-year survival, and almost 60% of the patients belong to this group.
Very good, Leo. So we have now presented for you how our test, Histotype PX Colorectal, can be used in a standalone basis, and that is a very solid test. We have also shown that it can be combined with the liquid biopsies to even further increase the accuracy, and the combination of them is excellent. And if you were here at ESMO, the main conference a month ago, you would also see that the de-escalation trials with ctDNA alone were negative. They did not meet their targets. So it was inferior if you only made your decision based on ctDNA. And then we can also combine with genomic analysis or multi-gene panels that also has a potential, because we know that, and we see that they are additive to each other. And then we are also focusing on further expansion into other indications like metastatic colorectal cancer, prostate, and a few other indications. We have an extensive pipeline of validations up and coming. You saw some of our data now, but we have collaborations across the world from the National Cancer Center in Japan, also now soon working with the Mayo Clinic and one of our advisors, Frank Sinekrope. And this will generate clinical data in 15,000 patients over the next year or two. And that is important because oncologists are careful people. They want to see the evidence before they change treatment practice for the patients, and for good reasons. But with this pipeline of projects and collaborations, we think we will get there. And we also have commercial partnerships with image management systems. So for the labs that already have gone digital, they can easily implement our algorithms on their platform to even further simplify the logistics around the tests. But we are also open for more collaborations, running validation trials on your data, on patients from your institutions or trials that you've been involved in. So that is definitely of interest, and we typically see that we can very efficiently generate lots of interesting data, getting posters, getting oral presentations, and certainly also publications. And then as a next step, doing clinical utility trial or pilot studies, pilot use of the test. Or potentially also taking part in developing new models. So we also have some other projects to develop new models. So, yeah, reach out to us. We are at booth 02, just behind you. Or send us an email. We're very happy to discuss more with you about Histotype PX and how we together can bring AI to better patient care. Thank you very much for your attention, and we're open for questions, if there are any.
Are there any questions?
Hello, good afternoon. Maria Castro, medical oncologist. I may have missed it, but I didn't see any data on the prediction of chemotherapy. Because, as far as oncologists, and you were right that we're very strict and careful, it doesn't really add as much if it just tells us about prognosis. Because we have known that for many other tests that we've been examined before you, that prognosis doesn't mean that the tumor will gonna respond and have benefit on chemotherapy. So do you have trials on that? Do you have validation on that process as well?
That's a very good question. So I would say that our data today on prediction is still indirect based on some of the things I presented. But we have additional studies that are in progress, which I think will further bolster the data I've shown, where we have patients both treated and untreated with similar characteristics, where we can show that perhaps the benefit, there's very little benefit in the low-risk classified cases. We also are in planning stages of a potential prospective trial that would definitively answer that question, but of course that will take some years to get the first readout. But we do think we will have quite good evidence even before a prospective trial.
I would like just to add also the data from the Galaxy trial, where you were CTA negative and low risk, there were no benefit of chemotherapy. And we also see that was not shown here, but the data show that for high risk and intermediate risk, there is a benefit of chemotherapy, even regardless of ctDNA status. So those data will come quite soon. It's not a randomized trial, but it's observational, and it's been used also for evaluating the Signatera test. We also have the data we showed from Utrecht. We will now compare those with patients who actually did receive chemo. It's again not the randomized data, but it will be inverse probability weighting to make as comparable groups as possible. And also the Ohio data that we present here, we also will, half of them were treated, half were not treated. So yeah, it's 500 in total, but it's building evidence on that.
Muaz Mubarak from Baghdad, Iraq. My question is, would you recommend to go through Histotype PX as a single test or to combine it with the circulating tumor DNA? This is the question one. And the question two, back to what's being said by my colleague. As far as I understood, it's kind of prognostic rather than a predictive test, because it's more or less, it's depending on the histopathology features. I mean, the poorly differentiated, the tumor size, infiltration. So I as far as I understood, it's kind of prognostic rather than the predictive test for the response of chemotherapy. Thanks.
It is trained based on prognosis, but it's trained on mostly non-treated patients that do well without treatment. So we believe, and what we've seen so far is that it also will be predictive of treatment benefit or not. And then we think, I mean, the data so far shows that on a standalone basis it's a very good test, and much better than the current tools available for making those decisions. But ctDNA is certainly coming at a high speed in colorectal cancer, particularly in the US. It's starting to be used now. So if you can afford both tests, that would be the best. As also Leo showed that 60% of the recurrences were identified by Signatera, 69% of the recurrences were identified by our test, and together they identified 86% of the recurrences.
Hey, Imre Gaspar, data scientist. I have also two questions. One, probably you mentioned it, but I missed this. How do you benchmark your model? How well it trained? Is it on an individual level or a population level? This is one of the questions. And the other question is that how do you see when you would move to other indications outside of colorectal? Would you have just one single model integrating all, or would you build individual models for each different indications? Thank you.
So it is validated on large data sets in 1,000 patients or 1,100 patients in the Lancet Oncology paper. But then you have some variation between scanners and labs and so on, and we've also worked quite intensively to reduce or to increase the robustness so that it's applicable across different scanners and labs to avoid that patients are classified differently between different scanners. And in terms of how to say scalability or using it in other indications, then we would need to train, at least if it's a different cancer, we need to train separately. It can be transferred within colorectal cancer, we know, but if you want to develop algorithms for other cancers, then you need to start with those data sets. So it's not like a foundation model that can be used across all tumors. Okay. Very good questions, and again, thank you for your attention, and feel free to come by our booth or talk more.
Thank you.